This is Dr. Lindsay Van Dyke, and today we're going to talk about overactive thyroid disorders. So in general, overactive thyroids and underactive thyroids are extremely common, and these conditions appear most frequently in women. An overactive thyroid, it could be temporary. It could be caused by pregnancy or short-term inflammation called thyroiditis, and that might be caused by an illness or medication. Or it could be permanent, like Graves' disease, or these so-called toxic nodules. There are 3 ways that we treat all overactive thyroids. Number 1, medication. The drugs called Methimazole and propylthiouracil, or PTU, block production and release of thyroid hormone. It also reduces the conversion of T4 thyroid hormone to the active form T3, which occurs in all of the cells in your body. A second way to treat overactive thyroids is radioactive iodine. This is a pill that contains an isotope of a certain type of elemental iodine, and its job is to decay and burn out the overactive gland or the overactive nodules inside an otherwise normal gland. The idea is if we burn out a part of it, you don't need to take thyroid hormone, but you also wouldn't need to take anti-thyroid medication like the Methimazole or PTU. Surgery is always available to people who are unable or unwilling to take medication or radioactive treatments, or for those whose goiter is so big it's obstructing their breathing or swallowing. So patients ask me, I have an overactive thyroid, but I feel so good, so what is the big deal? Well, we know from lots of long-term data that even a very slightly overactive thyroid can quote-unquote chip away at our muscle mass, bone density, and heart health over time. I've met many patients over the years who want to help lose weight, so they think they'll take an extra pill of their thyroid hormone, but frequently it does not cause weight loss. It does cause anxiety, osteopenia, and heart arrhythmias. Patients always want to know, what is the deal with antibodies? You have lots of doctors out there that check antibodies all the time. And what we can say is that the thyroid antibodies only really matter when a person has biochemical, on the labs, or clinical evidence, that would be the symptoms, of thyroid dysfunction. When antibodies are present, but that thyroid is still functioning totally normally, we do know that the risk of developing a thyroid condition is increased over the next few years, and it does deserve some surveillance. Graves' disease can specifically be detected by a thyroid-stimulating immunoglobulin, which is also called a TSI, or the thyroid receptor antibody, what we call TRAB for short. The TRAB is actually more precise than the TSI, which has been around much longer. So if a patient has positive antibodies, is he or she at risk for other autoimmune problems? Well, technically the answer is yes. Antibodies are like birds of a feather that flock together. That being said, it's very common to treat thyroid disease only as an isolated problem. And even though I am attentive at screening patients appropriately for other autoimmune-related problems when I already see them for thyroid disorders, I have most of those patients that do not have any other autoimmune problems. How does a patient know if the thyroid is overactive? Well, the classic medical school textbook symptoms include anxiety, a big thyroid that you might be able to see, sweating, diarrhea, a bigger than usual appetite, but even though you eat more, you keep losing weight. Periods may change and become very sparse. People with Graves' disease will notice that their eyes begin to protrude outward. And if you've seen Young Frankenstein, Marty Feldman's character Igor had Graves' disease. People complain that their nails will become very weak, soft, peeling, or split. They will complain of heart palpitations or feeling hot all the time, even when their friends and family say, it's totally fine in here, you are crazy. The important thing to remember is that thyroid symptoms represent a spectrum of disease depending on how altered the hormone levels are. So it's important to look at the whole picture and address other causes for those symptoms too. Let's talk more about the medications for overactive thyroid. Both methimazole and PTU act to block thyroid hormone production and the release of hormone from the gland. PTU is especially good at reducing that conversion of T4 to T3. Methimazole is our first choice for a medical agent to address an overactive thyroid. There are a couple of exceptions to this, and that is if a patient is pregnant or if he or she cannot tolerate the drug methimazole. Both of the medications carry a rare risk of agranulocytosis, and I'll say that it's sufficiently rare that I haven't even seen it in real life yet. It's a textbook concept. Agranulocytosis means that the body can't produce the right blood cells, and we don't know why these medications cause this problem. But if you take this medication and you have a new fever or acute illness, it is fundamental that you have your blood drawn that same day to check a blood count and confirm you are making the right white cells for your immune response. If you have a diagnosis of agranulocytosis at any time, it is reversible by discontinuing the medication. We know that treatment for an overactive thyroid is adequate when we again check the TSH and the free T4 about 8 weeks or so after starting treatment. Let's talk about what those numbers mean. Thyroid signaling exists in a feedback loop. The first signal, which is the TSH, or the thyroid stimulating hormone, starts in a gland in the brain, kind of between your eyes. And its job is to ask the thyroid gland in your neck to make hormone. That's the T4. When the gland is unable to make enough hormone, that signal from the pituitary gland, that TSH number, continues to get higher and higher and higher. It continues to demand more hormone. In the opposite problem, where the gland is making too much thyroid hormone and it's ignoring the feedback, that TSH number will completely shut off. We won't even be able to measure it. So when someone is overactive and they're making too much of that T4, and then we treat them, and 8 weeks later we check again, if that TSH has gone back to the normal range, then that is the sweet spot. The Endocrine Society states that achieving a TSH anywhere in the normal range is considered a treatment victory. So in the cases where symptoms are persistent, even when biochemically on the lab we know that that thyroid is back to where it's supposed to be, then we, as a patient and a doctor together, need to go back to the drawing board and consider other causes for those symptoms. If you have additional questions about overactive thyroid, you can go to the American Thyroid Association at thyroid.org or to the Mayo Clinic at mayoclinic.org.